Before we approach the patient in the operating theatre, we need to make several decisions, and we are now going to discuss the surgical considerations in the highly myopic eye. It is challenging to operate on a highly myopic eye, and the main issue is that of the long axial length. With underlying thin scleras, thin retina, and a thin choroid, there also is the issue of the lens that we need to make a decision about before we plan for surgery. The axial length is the big issue. It will determine how well you can do the surgery, what type of gauge you're going to choose for the surgical instrumentation, which has the impact in terms of length of the instruments and the rigidity of the instruments because of the membranes that we have to peel. These instruments have to be verticalized to reach the posterior aspect of the eye, and that results in risks of knocking of non-contact lens systems, and so you may want to consider contact lens systems. And with this vertical positioning of the instruments, certain surgical maneuvers may be limited. There's also, because of the verticalization, distortion of the wound and the cornea and the sclera, which can then disrupt surgical view, and also manipulations can have impact in terms of the self-sealing sclerotomies, especially in these highly myopic eyes with thin scleras. I generally would recommend performing a pre-op axial length measurements on all highly myopic eyes prior to vitrectomy surgery. And if there's an issue with the posterior cephaloma, a good pre-op B scan can help guide surgery. With the underlying high myopia, getting a good axial length measurement will determine whether we can use a 23 gauge, 25 or 27 gauge surgery. Usually I take a 30 millimeter cut off. If it's longer than 30 millimeters, I would use a 23 gauge surgery for surgical instrumentation. If it's less than that, we can go with a 25. However, you can also consider hybrid surgery and enlarge the right hand port to enable 23 or 20 gauge instrumentation. Some surgeons remove the trocars so that they have a bit more length. You can use ultra-long instruments which are available, and some surgeons even use curved instruments so that they don't knock the viewing system. Valved or non-valved? Generally, I would recommend a valve system. This provides greater globe stability. Remember that these highly myopic eyes have got thin scleras, and after you have removed the vitreous, it's easy for the eyes to collapse as you move in and out of the eyes with the instruments. You want to reduce internal turbulence as well, particularly if there's a detachment involved. And if you are attempting to perform an ILM flap, a free flap, or transplanting an amniotic membrane, you want to have a stable internal system so that the membranes and the flaps don't fly about and get lost inside the globe. These instruments would be beneficial. You need forceps to peel the membranes. Sometimes you need others to initiate the peel, such as loops and diamond dusted scratchers. You need to ensure that you have a good enough soft tip, long soft tip cannula so that you can dry the eye all the way down to the optic nerve. And you can also use other little tips and tools like the Nagpal massager to try to get the macular holes to close. Visualization is important depending on what you have in your operating theatre. There's the contact lens versus the non-contact lens viewing systems. You have dyes, which we'll talk about later, the endo-illumination, and as you use the different dyes, you may match it with different light filters to enhance visualization. And of course, nowadays we have the 3D heads-up viewing system in high definition and high magnification to enhance surgery. Intraoperative OCT can guide as well as to watch out for complications, and then you need to consider whether you need to remove the cataract if there's an underlying cataract, as well as high myopes tend to develop cataracts at an earlier age. The underlying thin retina and choroid gives really limited contrast. There's also vitroschisis and very adherent posterior cortical vitreous. These can potentially impede surgery and peel. So we use dyes and stains to facilitate and enhance surgery. The vitreous in the myopic eye can be challenging. There's usually a pocket of posterior cortical vitreous that can remain on the surface of the retina, even though you think you have completed the PVD with a vice ring formation. But the PVD must be complete with the posterior cortical vitreous removed so that you can access the internal limiting membrane and the epiretinal membrane so that you can peel it nicely. So we can use various stains and dyes like triamcinolone or lutein dyes or brilliant blue to enhance the surgical view. So in this example, triamcinolone is used to dust the posterior cortical vitreous, and you can see that it is removed more easily. And in this eye, we used brilliant blue to show that pocket of persistent cortical vitreous, which can then be lifted off the retinal surface so that we can access the membranes on the retina more easily. As you complete the PVD, you have to also remember that these highly myopic eyes can be treacherous in the periphery. You watch out for abnormal vitreoretinal relationships, that as you peel off the posterior vitreous and posterior hyaloid, there might be iatrogenic breaks along lattice, and you might have to laser those. So when we move to stains to enhance visualization, there's membrane blue, triamcinolone, indocyanine green, and these will help with visualization to ensure that adequate peeling of the membrane has been done. And then you need to make a decision about whether you need to include a tamponade at the end of surgery. If it's just a plain peel of the internal limiting membrane in an eye with stage 4 schisis without the macular hole or macular hole detachment, you could do away with a tamponade and leave the eye just filled with balanced salt solution. But if there is a hole or a detachment, then tamponade would be required. Myopic eyes have an underlying risk of glaucoma, so you want to beware about overfill and about your percentage of gas dilutions. Long-acting gases can also take longer to clear in a highly myopic eyes, and generally at first go we would use a gas instead of silicone oil because silicone oils generally do not conform well to abnormally shaped internal structures, especially when there's a posterior staphyloma present. So you may not get adequate tamponade. Sclerostomy management, just be careful at the end of the surgery as you pull out the trocars and the pods. You need to make sure that the wounds are really self-sealing. The scleras are thin. If you have manipulated a lot, it might have stretched the sclerotomies. You occasionally may have to stitch the eye. I would usually use the single pass transconjunctival transsclera with an absorbable suture, and that usually works quite well. Very often, these eyes have an element of lens opacification. So you need to make a decision before going to surgery whether or not you're going to remove the cataract. This might impact in terms of your surgical view. So you want to have a good view with the underlying poor contrast. Removing the cataract would be beneficial. But then there would be challenges in terms of IOL implantation, biometry challenges, and then what to do to match with the fellow eye. And these are important decisions that you need to discuss with the patient prior to surgery. So in terms of the surgical decision making, once you've got the indication for surgery, you need to decide about cataract or just a plain posterior vitrectomy. You need to decide about what gauge you want, and then the type of valve or non-valve system. You need to make sure you've got the adequate instruments. Do you have forceps that are long enough? Do you need a loop? And what stains are you going to use, the viewing system, and then depending on the underlying disease, whether it's a schisis, traction only, or is there hole or hole and detachment, you want to decide what type of ILM peel technique you are going to approach the eye with, and do you need a tamponade. And at the end of the surgery, make sure that the eye is a nicely formed globe with good pressure before you close up.